It's my pleasure to invite Dr. Naveen Thomas, our previous director, but for me, most importantly, he was one of our most important supports in helping us set. Whenever we needed anything, Sir was always there as our backbone. But primarily today, he's here in his capacity as our main pediatric surgeon. So many of our children have smoothly, effortlessly come out of fundoplication and surgeries. Thanks to you, sir. On to you.
Yeah, just wanted to tell all of you that, the parents that I have encountered, parents of SMA children, have been the real heroes. I think it is not out of place to give yourself a round of applause. And yes, the team which is caring for them, starting with Dr. Ann to all those who have contributed today, I have seen a tremendous amount of dedication and must congratulate every person who's involved. And thank you for that. So it's a wonderful occasion. Just to go out of this topic, there was this 3-year-old child who was brought to my outpatient clinic by the parents, and the parents were trying to tell the child, go say thank you, go say thank you, go say thank you. And the child was saying, no, I will not say thank you. But finally, before they left, the child went loose, escaped from the grip of the parents, ran to the place where I was standing, stamped on my foot and ran back. This was that little child saying, this is what I think of you. But surgery is not that bad. And we are basically plumbers in this. Whatever we are told is necessary, we do that ultimately. And but I must say, when we obey them, the pundits, usually things go right. And we have a wonderful system, I'm sure, of pediatric anesthesiology and post-op care, and Dr. Ramya just spoke, and all the input, not just the technical part. Yeah, and we have already talked about the GERD part of it, gastroesophageal reflux disease. Now, in SMA children, it is not just the reflux. It is even taking the food, opening of the mouth, the tongue movement, and swallowing, and all these things which are affected. So even saliva itself can be aspirated, but the sudden reflux is something that makes the child choke, aspirate, and they can be small subclinical incidents to major events. And that is something that can be missed. Even contrast studies, you've all heard of barium that is swallowed, x-rays are taken. Sometimes even that may not show up a proper reflux because it may not be there all the time, but suddenly it can happen and aspirations can really happen. Now, normally, there is in the lower part of the food pipe of the esophagus, there is this mechanism of higher pressure. It almost acts like a one-way valve, relaxes when food, water, liquids go down, and on the other way it stops. But at the same time, it allows some amount of regurgitation, the normal amount of regurgitation, vomiting, when it is necessary. But in these children, it tends to be much more lax, allowing reflux much more in a much more frequent fashion. We don't have to go into the details of the mechanics of what is involved in it. But when it comes up, remember, there is acid in the stomach, isn't it? Hydrochloric acid. And so the stomach content, when it comes up, it's not just liquid, it is acidic. And it is like this chemical pneumonia, because what is aspirated contains acid. Can you imagine? What an insult to the lungs, to the airways, to the air cells. So, to the parenchyma of the lung. So, that is what we want to avoid. Again, so it was a wonderful thing. I wonder how they came across these things when they initially started. This is a simplified version. The top of the stomach, it can be wrapped around. It's not so straightforward because a lot of blood vessels are there. It has to be safely disconnected. Space has to be made behind the lower end of the foot pipe, and then it has to be wrapped around. It should not be too tight. It should not be too loose. They tried with half a wrap, full wrap, and suturing it. Now, mind you, in open surgery, this is the most inaccessible part. It is deep inside at the apex of the abdomen where it meets the chest. So you need a very big cut, and even then you cannot see it right. That is where laparoscopy made the big difference, because you can see it so well. Vision is not a problem. And then, the surgery becomes much easier to do. Now, when you think of surgical, surgery theater, operation theater, it is frightening for the child. So, older children, they are brought to the preoperative area along with the mothers, because they are aware of what is happening till some sedation is given. Younger children, we are able to manage very well. They are not as anxious as parents even, and when they go in, they are able to handle very well. As I said, laparoscopy has made a big difference. Vision is excellent, and that is what is done. This is one of the pictures taken here. So you can see the sutures, the third suture being put, the stomach is wrapped around and creating the proper fundoplication. What you see on the right side, on your left, patient's right, that is the liver, which is retracted, pushed away, and stomach is wrapped around. Now, earlier, what used to be done was making a cut, holding the stomach, and putting Foley's catheter. And Foley's catheter is what is put to drain the bladder, urinary catheter. That was used, and it is still a useful thing to do. But the problem is, it is an irritating substance, latex, and it is not good in the long term, and feeding becomes an issue. Now, one of the good things is this called the Mickey button, one of the buttons which is available, and some of you are experts. I see Mr. Naveen Kumar, who's helped a lot of parents over the phone, how to manage it, how to take care of this. It is an excellent material. It has an excellent material which is non-irritant, and you see the bulb. Now that goes into the stomach, and it may vary from 3 ml to 7 ml that we push, so that the button sits well. It is not too loose, not too tight. Should be able to turn it on the abdomen, and it is an excellent contraption. Various sizes are now available, and we are able to use that. And I see some more faces, some more parents who very successfully used it, and you have done very well, and excellently well. And in fact, you become much more of experts than the doctors who handle it. This is one of the pictures of, soon after surgery, when we took off the bandages. So, very much easier to handle than the Foley's catheter. Now, this is not required for all the people, but many children may need it. And your pediatrician, your pediatric neurologist, they will be able to advise. And it is not as bad as we think. In fact, parents look back and say, oh, it was not that bad. But then, yes, any surgery should not be undertaken unless it is necessary, because anything like that is like crossing the road, though we say it is safe. We all do that hundreds of times, but crossing the road has its risk. So when it is necessary, we do that, and we thank God for the support structure available and post-op care which is available. So this is just an overview. If you are advised to do that, don't hesitate, don't delay, because it becomes worse later on. And when it is not necessary, definitely you don't need it. And your pediatric neurologist, your pediatrician, pediatric intensivist, they'll be the people who will tell you, or the pediatric pulmonologist, who will be a geneticist, yes, who will be able to tell you whether it is necessary. And if you need it, plumbers are ready. God bless.